by increasing heart rate. However, as this is prolonged, there is a reduction in cardiac output leading to hypoxia and eventually causing shock. The administration of fluid in septic patients aims to reverse hypovolemia as well as improve cardiac output and venous return. Due to sepsis patients having a deficit in retaining fluid, the administration of saline in the pre-hospital environment is vital. It is worth mentioning that there is evidence opposing the efficacy of fluid administration in the pre-hospital environment. This is due to reports claiming an insignificant improvement in mortality rates. Furthermore, fluid is opposed due to the potential risk of fluid overload, causing tissue edema, resulting in harmful outcomes as it can lead to increased cardiac demand, pulmonary and peripheral edema, and respiratory failure. However, fluid administration is effective and should be continued in treating sepsis due to the possibility of rapid decompensation if fluid is restricted. An effective approach was outlined in the International Management of Severe Sepsis and Septic Shock, stating that fluid administration is indeed effective so long as the healthcare professional considers the patient's presentation to determine the appropriate time of administration, the correct dose, and the most effective type of fluid to give, while reassessing the patient regularly to avoid tissue edema. Overall, despite the possibility of ineffective therapeutic interactions, in life-threatening situations such as severe sepsis and sepsis shock, it is more beneficial for the healthcare professionals to administer fluid and attempt to reverse the hemodynamic effects than not intervening at all. Another condition where fluid administration is indicated is in burns patients. During a burn injury, the body reacts both locally and systemically. These autonomous responses to severe burns can lead to detrimental consequences, and why it is imperative that intravenous fluid therapy is an immediate first-line intervention. Locally, there is a large portion of the endothelial burn that is potentially salvageable if there is adequate perfusion maintained. If there is insufficient perfusion, the injury will widen and deepen, causing further loss of tissue and function. Systemically, cytokines and additional inflammatory mediators are released once the burn affects a minimum of 30% of the total body surface area. This instigates an increase in capillary permeability and therefore movement of fluids into the interstitial space, which overall causes a large amount of fluid to be lost. This reaction can lead to hemodynamic instability and eventually hypovolemia. The use of intravenous fluid resuscitation helps to maintain perfusion to these areas by replacing the fluid that is lost during a burn. Isotonic sodium chloride closely mimics the fluid lost and therefore helps in maintaining blood pressure and tissue and organ perfusion. This in turn can prevent further tissue loss and enhance recovery outcomes. Research conducted on the outcomes of fluid resuscitation also shows that earlier IV fluid therapy, particularly in the first 24 to 48 hours, decreases the risk of mortality and increases overall outcomes, including renal and pulmonary results. It is important to note that fluid therapy in burns should be calculated appropriately and carefully by either using the Parkland's method or a similar method and monitored closely using a patient urinary output and other perfusion indicators. Overall, it is clear that the use of fluid therapy in traumatic burns is essential in general patient outcomes. In conclusion, it is clear that the use of fluid therapy is imperative in the pre-hospital management of a diverse range of conditions, as well as patient recoveries and overall health incomes. It is also a cost-effective and widely available resource, which makes it essential for the pre-hospital practice. Hopefully, you can now see why we must continue with the use of fluids in the pre-hospital setting and have a better understanding of the benefits of fluid therapy. Thanks, guys.